Hello, my name is Arlene Gorelick, and I'm the president of the Epilepsy Foundation of Michigan. I would like to introduce you to a presentation from our recent Wellness and Epilepsy Conference entitled Open Forum. An open forum is an opportunity to answer a number of questions around pediatric neurology. We're pleased to have Dr. Iqbal Allarakhia here with us today answering those questions. Dr. Allarakhia is a pediatric neurologist with over 15 years of experience in pediatric epilepsy. He's with the St. John's Health System. His presentation is sponsored by St. John Providence Health System. We hope you will find this presentation useful, and please remember that the Epilepsy Foundation of Michigan is here for you.
As Arlene said, I'm a pediatric neurologist, and I've had additional training in epilepsy, and my main area of interest is epilepsy, but I treat a whole range of neurological conditions in childhood. I think I'll open the forum by, ask if you have any questions. We can start off. And you can interrupt me anytime if you think I'm not saying something clearly. I don't have anything prepared to present. I assume that this will be driven by your questions. Go ahead, please. Yeah, I mean the Dayastat has been a wonderful addition to one of the ways to treat either prolonged seizures or recurrent seizures, and it's very useful for that. But like you said, it's a kind of invasive, especially for older kids and adults. They don't want to be seen being given rectal medication. There was a study which looked at midazolam, which is Versed, and it was given nasally, and it was compared to Ativan or lorazepam, and it was found to be at least as effective, if not more effective. The midazolam or Versed was in the pipeline, and I'm not sure why it has been not yet been approved. They were going to bring to the market an administrator for, there'd be a battery-powered device where you could just press and it would spray the medicine into the nostrils, and it would get absorbed right through the nasal mucous membranes. So I'm not sure why it has not occurred. There are devices on the market. There is an atomizer syringe. It looks like a small TB syringe, but it's not FDA approved or sanctioned. So that's one option. There are several other options. For example, clonazepam can be used. Clonazepam is related to Dayastat or diazepam in the same group of medications, and it does come in a dissolvable wafer. So if you put it under the mouth, it dissolves and can get absorbed. The other option is to use the brand form of lorazepam or Ativan. Some people have used that for clusters of seizures, but it has to be given orally. And they say that the brand form of the lorazepam actually starts getting absorbed right in the mouth, through the mucous membranes in the mouth. There are other options you can use, you can use. Some people have used, this is strictly off-label, they were given rectal, Tegretol or carbamazepine in the past. They have given the injectable Valium or diazepam rectally, and similarly lorazepam or Ativan. The other option is the rarely people even resort to using a prodrug of dilantin, which is called fosphenytoin. But it has to be injected intramuscularly. So rarely people have resorted for very hard to control seizures. Now, anything you give orally, you have to be very careful. If a child is unconscious or still in the midst of a seizure, giving anything to the mouth can be risky, because it can go down the wrong way into the airways and cause aspiration or choking. So clearly, when I tell parents to use clonazepam, which is now readily available, or Ativan, which is currently available, I tell them not to give it if the child is sleepy, unconscious, or in the midst of a seizure. Now, I know that some people are prescribing Versed or midazolam, and can be given in the nose. Even if you don't have a spray, you can just drip it into the nostril and it will get absorbed. So some people have done that off-label. The Versed or the midazolam has been used for sedation, for pediatrics, for procedures. For example, if a child is going to have a procedure done like a spinal tap or EEG or some other procedure, it can be given nasally. So people have used that route. So I know that it's been in the pipeline. I think it will come soon. I'm not sure when. FDA usually has questions and which have to be fulfilled before a drug can be brought to the market. Go ahead. Another thing I have used often, this is again off-label, is Keppra or levetiracetam can be given orally, can be very rapidly absorbed. But again, you have to give it. This is off-label use. We use many things off-label when we provide care, but it can be absorbed rapidly if you don't have IV access.
So my son is 5 years old and started kindergarten, and we had a prescription for Dayastat to keep at the school on site. And he doesn't have a history of prolonged seizures, but just as an extra precaution. And I was curious to know, we sort of are keeping it there for as needed use if he were to have a prolonged seizure before we could get to the school and help him. But what would an EMT on site, would they typically have Dayastat on the ambulance, or would they use a different medication? The school nurse suggested that the EMT might actually do an intravenous drug, and I was trying to think, how could they possibly do that if a child's seizing? I thought was maybe the Dayastat could be an extra tool they could use. So I guess my question is, do you happen to know if an EMT were to arrive on site, what would be their typical protocol?
Most EMTs now have Dayastat with them, but some of them use Ativan and they give it intravenously. So they would start an IV in the ambulance or on the site. They'll bring out their pack and they'll start an IV, and they're pretty good at doing that. They'll start an IV and give the Ativan. But sometimes if they don't get IV access, they can, they will give Dayastat. I've seen, I always look at ambulance records of patients who come in and see, to help see what the EMTs are doing, and they can, they're able to give, I've seen them give Dayastat. Now, in the school setting, even nurses and teachers and on occasion even bus drivers, school bus drivers have administered the Dayastat. So it's, when FDA approves a drug, for general use, they make sure that it would be reasonably safe in the hands of anyone. So a babysitter could administer, bus driver or a teacher or a nurse. So it could be, it could be anyone, a parent where a child is spending the night, sleepover. So it's the good thing about Dayastat, it has been found to be safe with, even if someone got carried away and gave 2 or 3 doses, it would, besides causing sleepiness, it's unlikely to cause any other side effect.
I think Dr. Allarakhia, one, too, getting in touch with your, who is responding, your local fire department, and find out what their protocol is. if you have the Dayastat, would they, and the school gives it to them, would they be willing to administer it? And if not, what would they be doing?
Sure, go ahead.
My son is almost 3, and he's myelinating slowly, but he's continuing to myelinate according to the MRIs. And I'm wondering, do you think that the AEDs play a role in the slow myelination or the seizures, or do you know why a child would myelinate a little slower?
Generally, myelination can progress at variable rates in different individuals. In fact, there are some 15-year-olds who are not yet myelinated in the frontal lobe. So the myelination usually starts in the occipital or the posterior part of the brain and proceed frontally. There can be some variations in at the speed at which the brain will myelinate. As far as we know, there does not seem to be any drug which affects myelination, the progress of myelination. Now, there's one drug where there's been some concern that it might cause changes in myelination once you already have myelin, and that's the vigabatrin, but and that's only in animal models. There have been some MRI changes seen. So that's the only one drug I'm aware of which has effect on not the speed of myelination, but now many times when children or individuals have seizures, the underlying cause, many times unknown, may be responsible for slower maturation of the brain. And actually the last developmental process in the brain is the myelination. So as far as I know, the seizures themselves don't cause delay in myelination, and of the drugs, and there's only one drug which causes myelin injury possibly, but nothing affects the rate of myelination. Myelination is where the nerves get the covering, the covering of the length of the nerve. So it's part of the maturational process. Any questions?
Okay, my question. Can you hear me?
Yes.
Okay, it might be controversial, but I'm just wondering if you think anybody has seizures from vaccine injury. Do you ever see that?
Yeah, this is a matter which will take years and years to sort out. There's no doubt on the cellular level that, for example, from the pertussis, and people have used that in the lab in mice, and you can actually purchase pertussis toxin, which is derived from the pertussis immunization, and also from the wild-type pertussis bacteria. Can sometimes cause injury to brain cells, and we do see children from time to time whose first seizure occurred after they got one of the immunizations. The question is whether it was an incidental event or whether there was a cause and effect between the immunization and the seizure, the first seizure or regression or any type of event, neurological event which occurs. Clearly, sometimes these vaccines can cause high fever, irritability. The older pertussis or the whooping cough vaccine was associated with, in certain children, a small number of children who received the immunization would get extremely irritable. There would be, they could have a high fever and sometimes have a seizure. So there isn't any cause and effect clearly established now, but that does not mean that there would not be any injury. Early childhood is marked by lots of immunizations. If you look at the most current schedule of immunizations, children are getting immunizations every few months. And if they happen to get sick during that time, is it coincidental? Is it a cause and effect? That's very debatable. Now, having said that, many years ago, I worked in Africa, and I saw hundreds of children who had severe, illness, including death and brain injury from not being vaccinated. Since we hardly ever see measles or whooping cough. If you did go to a developing country, you'd see many large number of children who suffered consequences of not being immunized. So clearly, in short, yes, there may be some degree of effect of the immunization on a child's development or seizures, but the overwhelming evidence is that the immunizations have really improved health overall in the community.
So both of my children were diagnosed with epilepsy, my daughter with absence epilepsy and my son with generalized several types of seizures. And we were part of the Genome project, where there were blood samples taken and surveys that were done. And that was a couple years ago where we did that at U of M. And I was just curious if you were familiar with that study and what the status of that study is and what the hopeful outcomes are going to be, because I didn't really track the big picture of what that research might provide.
The information from the Genome study is sent to a central location. I don't remember where, but they keep a database. Many the molecular basis of many seizure types has been determined now. There are some which are determined, some which have not been determined, but they every few months you see a new type of epilepsy where the genetic basis of the molecular basis has been figured out, but there hasn't been any output from that the national project yet. But we expect that there will be a lot of information coming in the coming years. I think it'll be very useful. I think it's very important to consider having getting enrolled, especially if you have a family history, if you have more than one person affected by epilepsy, because the information can be useful for further future generations. I think it's very important. I think when we look at the future, we'll be treating epilepsy in a very different way as we do now. We will be more likely choosing medications or any different form of treatment based on the genetic finding and the biochemical basis of the epilepsy. So it's more likely, 20 years down the line, when someone has a seizure, they'll get blood drawn before they get an EEG done to check what gene they have. Do they have any mutation? So I think there is not much useful information except we know the genetic basis, but we don't. Now there are certain types of seizure disorders like Dravet syndrome where we know that certain drugs will make seizures worse and certain drugs are more useful. So we already are starting to get information on a very small number of seizure types where certain drugs are more effective and certain drugs which we thought were good are actually harmful in causing increase in seizures.
Just a kind of a follow-up on just that. You're speaking of the genetic factor. My daughter and two of her cousins, all first cousins related, all on the same side, have epilepsy. What's the percentage, or what is there any percentage or anything of that genetic connection? I mean, is there any
I think
connection there? Thought to have, well, at least two of them have the same type of epilepsy.
Yeah, I mean, they are. If you look across the board at all patients with epilepsy, especially if you look, focus towards seizures which start in childhood, the consensus is, even though we are not able to tell, certain genes, but the consensus is, and that's been for the past 30 or 40 years, that the majority of seizures which occur in childhood without any obvious insult to the brain. So if a child did not have meningitis or head injury or some other event, and it's more likely to be genetic. Now, having said that there are many genes which predispose to seizures, and the inheritance can be different kinds. If it's a recessive gene, then the odds are that a family may have only maybe one person every other generation affected by epilepsy. On the other hand, if they have a dominant gene, it's very likely that, you know, every generation may have one or two people affected by it. You know, so we know about a few genes. We know, for example, that absence epilepsy or Rolandic epilepsy or juvenile myoclonic epilepsy or Dravet syndrome or you know, certain forms of progressive myoclonic epilepsy where we know the gene and we can predict. But generally, you know, parents always ask me, you know, that, okay, you know, my one child has epilepsy. What are the odds that my other 2 children or 3 children will have epilepsy? And I tell them, you know, the general number is that maybe a slight increased risk because, you know, most of the genes are recessive. The other thing is that when you have a gene, you don't necessarily will have a seizure. For example, if you have a gene for benign Rolandic epilepsy, in fact, 1% of all children have a gene for predisposition to benign Rolandic epilepsy, but not all of them will have seizures. So you can actually carry the gene for a seizure, and if the environment doesn't challenge you with being sick, or you know, you will not have seizures. You can go through life without having a seizure. So there are many factors to look at when you look at whether a person will inherit. You know, how likely is it that a family will have 2 or 3 or 4 more people affected by epilepsy? Maybe about in 10 or 15% of families, I find that, you know, that there are more than 2 or 3 people affected by epilepsy. But having said that, you know, more than 50% of seizures which start in childhood are felt to be genetic in origin, even though we may never find a gene. But we assume it's genetic because we don't find a tumor, we don't find a stroke, we do an MRI, we do a detailed testing, and we never find an obvious structural cause for the seizures.
Is there a gender difference, more boys than girls, more girls than boys?
Generally, boys and girls are equally affected. You know, there are certain types of epilepsies which may be slightly more prevalent in certain genders. For example, the absence seizures or petit mal seizure, which start in early school age children, there may be a slight predisposition for that to occur in girls. We know that around menarche, you know, when girls start having periods, that's the other time when seizures may occur slightly more often. You know, we know that the estrogen has a convulsant effect, so there may be a slight increase in girls having seizures around puberty compared to boys. But generally, most you know, epilepsy syndromes affect both genders equally, most of them. And it's most likely that if there are any slight gender differences, they may be more related to hormone status rather than the gene itself. I'm not aware of any X-linked epilepsy syndrome, you know, in terms of seizures. We are all a complex interplay between our genes and our environment, and sometimes the environment plays a big role if somebody has a genetic predisposition. Any other questions? Sure.
Is there any add-on therapies that are tested or whatnot, is there any add-on therapies or any type of new research that's coming out in the open that's showing promise for either controlling seizures or becoming maybe more of a cure for epilepsy?
I'll begin with the end question, which is, are there any seizure, medications which will cure seizures? It's unlikely at this point, at least in the very near future, that we have any drugs which will completely render everyone seizure free. Now, there are a few drugs in the pipeline right now. Some of them have just been approved. There's rufinamide was approved in the recent past. Vigabatrin was approved as an add-on therapy, and clobazam, which we are getting from Canada to treat patients, has been approved by FDA for prescription here, and those are all good add-on treatments. There's izogabine, which is just been approved, and it will be available soon. There is a drug related to levetiracetam or Keppra or brivaracetam, which is, my knowledge, may be approved very soon. There are other drugs like perampanel, so there are a few drugs in the pipeline which are, which are going to be approved. So I think in the coming 5 to 10 years, you'll see at least 5 or 6 new drugs coming into the market, maybe even more. Some drug companies don't advertise their drugs. They keep everything under wraps until the very last minute. There are other devices, devices like I'm sure you're familiar with the vagus nerve stimulator. So there's a NeuroPace device which has been used. There's a thalamic stimulator, which is, and those are pretty, I'm not sure how far they are from approval, but these are devices which are likely to get approved. The NeuroPace device is a responsive electrical stimulator which is put on the area where the seizures come, and it actually senses the seizure and delivers an electrical current to counteract the seizure. And then there's another device which is inserted in the thalamus, and that's a little bit far from approval. I was aware some years ago of a device which stimulates the cerebellum. It would be a very new approach to treating seizures, but that would be quite far from approval.
Well, I have a question regarding the impact of AEDs. I'm back here, sorry.
Yeah.
Our daughter's been on medication her entire life, and I've done some research and attended seminars, and I just wanted a refresher in anything new regarding neuroplasticity. She's 14 now, and we feel like we are battling a clock, that these things have been an interference for her development all along. And are they thinking that neuroplasticity is a little bit longer than they used to? Because you had this window that kind of coincided with school age. But are they thinking now that there is room to, get in there, provide the right stimulation, and keep the development going a little bit longer than in the past? Plasticity, just to define, is a phenomenon by which the brain compensates for deficits, whether it's from injury or from occurrence of seizures, which cause a negative effect on the brain, and so plasticity is means by which we are able to regain or acquire new abilities from a neurological standpoint. The biggest opportunity for plasticity, which is to make up for any injury or deficits, is in early childhood. Now, it does not mean that you close the window for plasticity even as an older person. We know, for example, that even when an 80-year-old person has a stroke, they do have plasticity because they are able to recover their function to some degree. Clearly, the potential for plasticity is maximum in the younger population. For example, if you had a newborn baby and you completely damage the language area, which will be on the left side of the brain in most people, you will end up with a completely normal language because the language would entirely transfer to the other side of the brain. The plasticity can occur even after 16, even as a young adult, even as an older adult, although it becomes less robust, less forceful, but you don't close the window for plasticity even in an older person. So it's very important to continue with all the educational interventions and the extra help and the accommodations you get at school. Any more questions? Go ahead.
Okay. Well, thank you, Dr. Allarakhia. Anybody have any questions as far as, I know someone talked about the school and rectal diastat. Was someone at the beginning talking about that and the other forms of rescue medication that are used? And they were asking a little bit about the difficulty of getting the schools to administer it, the rectal form. Was there someone who was talking about that? Okay.
We haven't had an issue with the school not wanting to do it. It's just, you know, she's 10 and her peers are there and it's just embarrassing. So I was just thinking that if there was something coming down the line, and I think that he covered it very well.
You can speak to your neurologist and ask if they'd be willing to prescribe the Versed or the midazolam. It's off-label, but it's likely to be approved. The other choice would be the clonazepam, which comes as a wafer. As long as your daughter is not in the midst of a seizure, and if she's alert, you know, she could be given that, and it will dissolve in the mouth, and the likelihood of choking or aspirating would be very low. What I found very useful is to go to the Epilepsy Foundation's website, and they have a seizure action plan. They also have, directions and information for the school nurse and for the teacher, and sometimes, you know, if the school is giving you a hard time, you can ask your neurologist or your physician or sometimes the Epilepsy Foundation to advocate on their behalf. Because, you know, just like asthma or cystic fibrosis or cancer, you know, epilepsy is a condition which you want your child or any other person who has epilepsy to have as much normal life as possible. So that, you know, that means that should be able to go to school, they should be able to take part in sports, after school activities, they should be able to have sleepovers. You know, as much as possible, you like the child to be, you know, have as normal and as fulfilling life as they can. Many times, you know, if you can, the last time I looked at the Epilepsy Foundation website, you know, they have many links to information for teachers, and they have information, first aid measures specific to different kinds of seizures. So if you have atonic seizures or generalized tonic-clonic seizures or complex partial seizures or myoclonic seizures, you know, they have information specific to that. Sometimes, you know, if the school is very anxious, you can have them speak to your physician or nurse or the psychologist or social worker, and you can make headway. And there's a seizure action plan you can download. It's in PDF format on the Epilepsy Foundation website, and you can have, you know, your neurologist fill that out, which lists all the. It's already printed with first aid measures and the procedures to follow. You know, there's a place where they can put your cell phone there and the teacher's cell phone and the physician's number. So I think if you work with them, you know, many times you can make them accommodate you. Sure.
In regards to the Versed, in the clinic that I work with, we actually do prescribe the nasal Versed. We work with a compounding pharmacy who actually puts it into a nasal atomizer bottle. And probably the one disadvantage to it at this point is the shelf life is definitely shorter than what the Dayastat is, but it does really make it a lot nicer for the older kids to have that as use for a seizure, which can be given just, you know, at the time while they're having the seizure. So you don't, so it is definitely another available avenue. The pharmacy that we work with have been able to get it approved or get it paid for by your insurance companies. So it is available out there. The pharmacy? Oh, the Versed. The nasal Versed, which he had been talking about.
V-E-R-S-E-D. S-E-D, Versed, or midazolam. I think it may be very close to approval. You know, I've heard rumors of that, but we've been waiting for it for more than 3 years now to be approved.
Well, we do have a program at the foundation where we do have someone who's a registered nurse going out. If you do have a problem in the school, such as not having access to medical personnel or them not wanting to designate someone to administer the medications, we do have someone that will come out to the school as an advocacy protocol and do a full presentation for them, teach them how to administer the meds.
In the first presentation, the physician was talking about immunoglobulins, and I'm just wondering if you can tell us why they would do that.
There are certain seizure types. You know, people are looking now more at, you know, could there be an autoimmune basis for seizures? Now, in the 60s and 70s, there were some neurologists who, when children first started having seizures, they would give IVIG. It was questionable whether or not there was any benefit. We are now recognizing that there are new forms of encephalopathies, where an encephalopathy is where you have just an involvement of the brain. And we know that, for example, infections can affect the brain, but now we are more aware of autoimmune conditions where your body has antibodies to brain cells causing either an encephalopathy or seizures. You know, we now recognize that there's a particular type of refractory seizure called Rasmussen's encephalitis, where there is an antibody to the you know, the excitatory amino acid in the brain. We also now know that sometimes patients can get an encephalopathy from antibodies to the NMDA. NMDA is one of the excitatory amino acids or transmitters in the brain, and so I think you will likely see more targeted use of immunoglobulins in the coming years. When I say coming years, in the next year or two, there's some literature coming out that people are using immunoglobulins for certain kinds. So unlike in the past where people just use immunoglobulins randomly, you know, if you said that let's try something, so it was given more empirically or just without any basis, but I think in the future you might see more use of immunoglobulins. But as of now, there aren't any specific seizure types you can treat with immunoglobulins. But there's a lot of research going on, you know, and clearly if an individual has a recognized autoimmune encephalitis, like to the NMDA receptor, then clearly people are starting to use immunoglobulins acutely.
Is there a limit to the length of treatment?
I'm sorry, I didn't get.
Is there a limit to the length of treatment?
Oh, the length of treatment?
Yes.
Again, these are very empiric measures. The only established or recognized uses of immunoglobulins currently are if you have an autoimmune encephalitis, and it's you know, the NMDA receptor, but there are other receptors like glycine or glutamine receptors where people have used immunoglobulins. But even that is not established medical care at this point, so people are using it. So if there are seizures associated with that encephalitis, the immunoglobulins are used, but they are not used specifically for any chronic treatment of seizures.
Any other questions?
You know, the other thing I wanted to kind of bring into light bring attention to is bone health. You know, I was outside, and I think it's an important thing to consider in patients who are on epilepsy. medications on a chronic basis, especially in individuals who are developmentally disabled or and are not walking, are wheelchair bound. They're very likely to be low on vitamin D, and even though acutely in children you're not going to be worried about osteoporosis, but as they grow up, you have to look at patients through their whole life cycle, and you have to look into the future. And so I think we are more aware that we should check for vitamin D levels. Many patients with epilepsy will not have optimal or the best nutrition. They may not be able to eat well, especially if they're behind developmentally. The other issue is that certain anticonvulsants, especially the older ones which are enzyme-inducing type, like phenytoin and phenobarbital and carbamazepine, which induced liver enzymes, they can make a person's vitamin D levels very low. So I think it's good standard of care to check vitamin D levels and maintain good nutrition and give 3 servings of dairy products, or if not, give vitamin D supplementation with calcium. And it's not in childhood that you're worried about, but you're worried about bone health as you get older. So I think it's an important issue to think about. Go ahead.
Do you know anything about the laser surgery for epilepsy that they're doing like at Texas Children's Hospital? I think it's called Visual A's. Are you familiar with that?
No, I'm not familiar with that specific technique. There are surgeries that are done by laser. When you do surgery with laser, you're going to be more focused. You're going to reduce the likelihood of bleeding, and you'll have a quicker recovery time compared to if you did surgery with a scalpel. So that's all I can say about the laser surgery. But lasers have been used by neurosurgeons, for quite a while. The other thing I would recommend, since I assume that you are all parents or caretakers, caregivers for children with epilepsy, is to work with the school, not only regarding their seizures, but regarding the educational achievements and whether or not they need any accommodations. That's an extremely important thing to do. Epilepsy is a chronic condition, and just by virtue of the diagnosis, a child would be eligible for accommodations and extra help in school. So it's very important to advocate for your child. Very often, all you have to do is just write a letter to the school, and by law, the school has to respond or within a month. And this would include even the summer holidays. That if you feel your child needs help in speech or needs extra time to get the tests done, including ACT and SATs, they would be eligible for extra time. But you have to advocate up ahead, and because it takes time to get these things done. So it's important to work with the schools. And they can be very helpful even in these eras, in these times of financial cutbacks. There's still resources you can use and a parent would be the best advocate for their child. It's my late partner, Dr. Walker, used to say it's the squeaky wheel which gets the grease. So the more you advocate for your child, the more services your child will get, the more accommodation they will have. I think it's a very important aspect of care of children with epilepsy. You want to make sure they get the most out of their school or learning experience. Are there any questions? Could be any question, if I'm not able to answer.
Dr. Allarakhia, you talked about bone health, but are there any other preventive health issues that parents should look out for with children with epilepsy?
I think bone health is the most common issue. I mean, clearly, children who have very frequent seizures, you have to look at the risk of injury and look at the risk of pneumonia, which can sometimes occur in association with seizures. Those are the main issues to look for. Clearly, as far as possible, children should have their well child care visits on a regular basis, so that you can look for any concerns. But the bone health is the most important issue. For young girls, I think you need to worry about the time they have puberty, so that you take the necessary precautions for their well-being. But generally, you should have a very good family physician or a pediatrician, for your child, and that's where all the health care takes place, and the maintenance, well child care visits are very important to follow up on.
I have a question. I'm caring for my brother. He has had epilepsy now for a number of years. The majority of his seizures occur within 2 hours of sleep. And he's on 4 medications currently, and he also has the VNS, which has not, served him well. But the last medication that he takes in the evening is the phenobarbital, which he has been on all of his life practically. Is there any benefit and he takes the other medications twice a day, 7 a.m. in the morning, 7 p.m. in the evening. Is there any benefit in changing when the medication is given, or since the seizures occur within 2 hours of taking the phenobarbital, is that something that I should be considering having him wean from, or should he be taking the medication 3 times a day instead of twice a day or 4 times a day, or is there anything you can speak to regarding that?
There are many principles you have to think of in considering your situation. First of all, sometimes you can dose a medication in relation to when the seizures are most likely to happen. We know that 70% of all seizures occur during sleep, the timing of the phenobarb probably does not matter, because phenobarbital has a long half-life. So regardless of what time you take it, you'll have fairly steady state levels throughout the day. But if you're taking a short-acting drug, you might get a better effect or better control of the seizure if the short-acting drug was taken somewhat later in the night compared to earlier. So if you, for example, if a person was on carbamazepine or oxcarbazepine or levetiracetam, which are shorter acting drugs, and if the seizures always seem to occur 2 hours after going to sleep, you might consider postponing the time of those medications. Clearly, the other issue you raised was how often to give the seizure medications, and clearly, if you give someone a medication 3 times a day, you'd have a more consistent, level rather than ups and downs. So you'd even out the ups and downs in the blood levels, but then you have to also consider the lifestyle issues. When people have to take medication more than twice a day, there's a greater tendency to forget sometimes, or to take the medication. So sometimes you're better off taking a medication twice a day, even though you know that the levels will be more likely to fluctuate, compared to if you took 3 times a day medication, you'll get better sustained levels, more evened out levels rather than going up and down. But you have to balance the compliance issue against or the ability to take or to remember taking the medication if you have to take it 3 times a day. The other issue is using 4 or more drugs. We know generally that, again, this is just a general principle. It may not apply to your child, but the general principle is sometimes fewer medications do a better job compared to more medications. you reach a point where you're using, 3 or more medications or 4 medications, then sometimes you don't get that added benefit. So the other principle, and again, this may not apply to your child, is when you introduce a new medicine, you have to look and see which of the other 3 medications was useful. Because sometimes the parent is the best person to know, when, we added this medicine A and we didn't get any benefit, so maybe it's time to take away the medicine A and keep, so it's better from time to time to reflect, to look back and look at, which medicine was more effective and which wasn't, and maybe take away the ones which gradually, the medications which did not have any effect.
Dr. Allarakhia, I know you were talking about long-term effects, SIADH and Tegretol and Trileptal. Are there getting more and more studies into that, and people are prone to it?
SIADH is the also called syndrome of inappropriate ADH secretion. Then ADH is an antidiuretic hormone which is produced in our body to hold water. It's anti-diuresis. So, and 2 medications, particularly, Tegretol or carbamazepine and oxcarbazepine, have been associated with the syndrome of inappropriate ADH secretion. Now, when you hold on to water, you tend to dilute the sodium you have in your body. So, one of the effects of SIADH is that your sodium will go low. Now, having said that, most people who take oxcarbazepine or carbamazepine, maybe about 20% will have low sodium levels. The question are those sodium levels low enough to cause any seizures or problems? And in most cases, they don't. Your normal sodium range is around 140, 135 to 145, and when you have SIADH, it may run maybe about 10 units lower, so it may be like 130 or so. But generally, when people, people need to have very, very low sodium levels, generally lower than 120 to have seizures from the low sodium. Now, we know that children are slightly more likely compared to grown-ups to having, SIADH. And this is not from the literature, but when I was in my training, I took care of many patients with brain tumors, and it seemed that they were somewhat more likely to have SIADH compared to other populations. Now, if the FDA does not recommend checking sodium, in patients who are taking carbamazepine or oxcarbazepine, unless they are very sick or throwing up or something where they will be more predisposed to having low sodium levels. So even though, yes, you get SIADH, but usually it's not clinically significant to cause any problems. Any questions? So you don't need to check electrolytes or sodiums when you're on those 2 medications, except if a child is sick, is throwing up, has a virus, has gastroenteritis or some other reason for throwing up, then you should check the electrolytes to make sure they don't run lower on sodium. If you don't have any questions, I can maybe talk about injury prevention. I think it's important to know about injury prevention in individuals with epilepsy. I think even before you discuss medications for treating seizures, I think it's important to prevent the risk for injury. I mean, the most important factor to consider is water. There is an increased risk of drowning if someone has a seizure, if they're in a bathtub or a swimming pool. I never ask patients not to swim if they have seizures. That's my personal preference. Now, other neurologists may have different opinions on that, but I do say that if children or adults who have epilepsy want to swim, they should be supervised 100% of the time. And I always worry about
homes where they have pools in the backyard. Children just jump into the pool. And I tell them, look, you cannot go into the pool unless there is a grown-up who can keep an eye on the child or the individual who has seizures. I've heard of even adults with epilepsy drowning in their bathtubs. So I think it's important not to take a bath in a tub filled with water. I tell my patients that unless your parent is willing to be there 100% of the time, they should always have someone there. The other issue is related to helmets, and I think children should wear a helmet regardless of whether they have a seizure or not. If they are riding a bike or rollerblading or skiing or skateboarding. So helmets are very important. I tell parents that children need they should not let their children ride a bike or rollerblade unless they wear a helmet, and that applies to everyone. The other safety precaution is involving heights. Generally, the good rule to follow is that if you should avoid heights which are twice the height of that person. So if someone is 5 foot tall, they should not climb a ladder or a tree which is higher than 10 feet. Now you can always make exceptions. You use logic. For example, if they're using a play equipment and there are wood chips or soft surface around, maybe you can make allowance for higher heights. But generally, you want to avoid tall heights. I never restrict any sports for generally unless they involve heights. So I tell parents, yes, you can play soccer, you can run track. Only last week, a young 15-year-old asked me if he can wrestle, and I said, sure, you can wrestle. The safest place to have a seizure is when the coach is around. The coaches, all coaches are well versed in first aid for seizures or first aid of all kinds. So you do not want to restrict any sports. They can even play football, they can play hockey, as long as they wear the appropriate protective gear like everyone else. Seizure safety precautions are much easier when you are younger. When you grow up, it's a little bit more difficult when people start cooking on the open fire, and that should be avoided. For children, they can use the microwave. I think that's safe enough. But they should, if they have frequent seizures, they should not work with the open fire. Cook on the open gas or the electric stove. Fortunately, with children, we don't have to worry about using, power tools or chainsaws and things like that. But so it's much easier in children to talk about safety precautions because. Sleepovers can be quite good. They should be safe. If the child is going to have a sleepover, if you trust the parent and you tell them about the seizures, I think they can have a sleepover, but they should avoid sleep deprivation, which can sometimes act as a trigger for seizures. There was, I think, Dr. Agarwal. I listened in on the previous presentation, and she talked about her son going to France. And so, the sky is the limit. When your child has epilepsy, you should encourage them to do all that they want to do and not hold back. As long as you take appropriate precautions, your child should be able to achieve, get the most out of their life.
Dr. Allarakhia, talking about letting the child have some control also, as far as, having them accept the disorder, as far as them participating in, remembering to take their meds and things like that without a constant reminder. That transition for them to take control of their disorder, too, is very important.
It's very important. Now, having said that, there are some children who are very forgetful, I have 3 children, and one of them is very forgetful, and he's 23 years old, and he still doesn't take his medications regularly. And then there are 12-year-olds who are very responsible. Once you have a pill box and you put the medicine there, that they'll take it. So
you would know your child the best, and I think it's important to empower your child to make decisions and decide, what they like to do. You can always keep an eye on them just to make sure they don't miss taking their medication. The most common reason why children have seizures is if they miss their medicine. And that's the most common cause or the trigger for having a seizure. In fact, whenever I get a call from the emergency room about a child, especially a teenager in the emergency room with a seizure, first thing I ask them, did he take his medication? Because it's usually that the teenager forgot to take medication. So it's important to have, now you can buy pill boxes which have alarm in them, and you can get apps in your phone for reminding you when to take your medication. And children are very, very resourceful. If I have problems with my computer, I always ask my kids to figure them out for me. So they're very resourceful, and they should empower them. But you can get a lot of apps to do different things. I've had children who went to their school, and when they were asked to do like a show and tell, they spoke about their epilepsy. It was educational for everyone else, including the teachers. So, I think it's an opportunity you should take the opportunity to educate others about epilepsy. Every opportunity you get at school and.
Do you know what the driving laws are in Michigan, and what's your recommendation regarding things like driving?
The driving law in Michigan is 6 months, so you have to be seizure-free for 6 months before you can drive. Now, in Michigan, unlike some other states like California or Pennsylvania, the responsibility of the physician is to inform the patient or the family about that you should not drive for at least 6 months unless you are seizure-free. It's different from in some states. A few states it's 3 months, and some, but most states are 6 months. You have to be seizure-free for 6 months. Then there are certain situations like, some parents tell me, "Oh, my child only has seizures during sleep." And that's a difficult situation because if a child has a seizure, maybe once every few months during sleep, and should they drive? And I think you have to look at each individual case. Having said that, I also do sleep medicine, and I can tell you that more people have accidents from falling asleep by hundreds of times compared to having a seizure. But clearly the law states that you have to be seizure-free for 6 months before you can drive. Sometimes you can use that to your advantage. If you are a parent of a teenager who really wants to drive, you tell them, look, you take your medicine, and that really improves compliance. Sometimes as a parent you have to be kind of devious, So you can use that to your advantage for making sure your teenager takes their medication.
We have almost 3-year-old, and I've never given him a pillow to sleep with. And I keep thinking like maybe I should never give him a pillow. He has had seizures in the middle of the night, but it's been a while. He has a birth defect in his frontal lobe, and would you recommend that? No pillow? I don't know. I think suffocation.
Oh, you mean a pillow?
Yeah, a pillow to sleep with at night. I mean, he's almost 3.
In a 3-year-old, probably the risk is low, but if you're worried about it, you'd be better off not using a pillow. I go back to being a pediatrician. We tell parents that they should not even use bumper pads in their crib, for younger children and infants. We also tell parents, of infants, under a few months old, that they should not use a pillow or a bumper pad or heavy blankets. I think if you are concerned, I would not use a pillow. I would recommend against it. We don't need a pillow. I know it's very comfortable and it helps improve sleep, but if you're concerned, you should not use a pillow.
Any other questions? Okay, well, thank you, Dr. Allarakhia. I'm sure he's going to be staying here a little more for if anybody has any questions that you want to ask him privately, but thank you very much.
Yeah, thank you very much for your attention.